Okay, good morning. Good morning, everyone. Welcome to this webinar where we're looking at the longitudinal cohorts work that Smarten has recently published, that we commissioned Paul Heron and his team to produce. I am Dr. Nicola Byram. I'm the director of Smarten, and I'm going to be chairing the event this morning. I'm also a bit of a Zoom novice. I'm not a fan of it. I'm terrified by it. So I'm just going to hand over to Emma for a few moments just to let us know a bit about navigating Zoom for this morning.
Morning, everyone. Just to let you know that I'll be keeping an eye on the chat box today. So for those of you that are relatively new to using Zoom, there's a bar along the bottom and relatively in the middle of the screen, there's a little speech bubble called chat. So I'd encourage you to have that open throughout, just in case it's not open already. You can either submit a message to everyone or you can submit a message to individuals on the panel, which you can do so by clicking on the drop down everyone and select a specific person. So if you feel like if we're missing you, if you're putting your hand up and we can't see you, please do pop something in the chat and we will keep an eye on it and we can interrupt whoever's talking to bring people in from the chat as well.
And Emma, if people want to ask a question, how best do they do that? How do you pop a hand up?
So I'm just double checking myself because I don't use Zoom regularly. So I think it's in the reactions. Yes. So on the same, there's a black panel across the bottom towards the right hand side. There's a feature called reactions. If you click on that, it will open more options and you can raise your hand.
Okay. And if all fails there, please do unmute yourselves and just shout at whoever's talking. That's better than us ignoring you. If you haven't noticed as you were joining, we're recording this session as a webinar that Smarten will share at the end. So please just be aware that if you're chatting, if you join the conversation, you want to ask a question, you will be recorded. Okay, I think then we will get started. For those of you who are just joining us, I will introduce myself again. I'm the director of Smarten. I'm Dr. Nicola Byram. I've been leading this work around student mental health. I'm co-hosting this event this morning with Dr. Emma Brolier. Emma, would you mind giving a brief introduction?
Sure. Good morning, everyone. I'm Dr. Emma Brolier. I'm a lecturer at Sheffield in the psychology department, and I've been working with Nicola and with the longitudinal cohort team to help with some of the research into setting up cohorts into student wellbeing and mental health.
Thank you. So I've got up on the screen here a little overview for what we're planning to do this morning. So a little bit of an introduction from me, and then I will hand over very quickly to Paul, who has been leading the work, putting together this resource. And then we're really fortunate this morning to have with us Dr. Margaret McClafferty, Dr. Kieran Ballou, and Dr. Jax Bennett, who are happy to join us and tell us a little bit more about the work that they've been doing with longitudinal cohort data, both at their own universities and pulling in data that's available more widely. And they're going to tell us a little bit more about their work and then how they hope to use this resource and maybe how they hope the sector might use the resource. And then we've got some time at the end for a Q&A. I'm really keen to hear from the audience and hear questions that you might have around the toolkit and what we're hoping to achieve here. I'm going to stop sharing that slide so I can actually see people and you can see me. So let me just say that this is one of the biggest pieces of work that Smarten has commissioned. So Smarten started in 2018 with a view across the sector in the UK of considering considerable concern around student mental health. We felt as we went into the project that there was a strong sense of crisis around student mental health. And one of the questions that we were asking at the start of the research network was whether that was a realistic sense of crisis, and whether this was about being a student, whether it was about being at university, or whether something else was going on. And we were very aware at the start of the network that we were lacking in good data to help us really understand what was going on for university students. We're fortunate that over the last, I guess over the past 5 years, there's been some fantastic work with longitudinal data sets that are collected nationally that have helped us get a stronger picture of what's going on for students relative to their peers not in education. And we can see there that a lot of what does seem to be presenting as problems around student mental health is actually challenges for youth and emerging mental health for emerging adults more generally, and it's not specific to the student space. I think this has been this has had a big impact on how we understand what's going on for mental health within the university space. However, our understanding of the specific challenges that students are facing within the university context, I think still has a lot of work. It still needs a lot of work to try and understand what's going on there. One of the earlier projects that Smarten ran was a priority setting exercise with university students. We were working with students to understand what they thought were the research questions that the sector really needed to answer. And we took their questions and mapped them against a thorough review of the literature to identify whether the questions they're asking have already been answered and where those gaps are. And one of the things that students were picking out in that exercise that does seem to be a gap in the literature is how the university context, the university environment impacts student mental health. And the kinds of questions they're asking is, do we see variability across faculties? So if you're studying different subjects, are you going to be more likely to be struggling with your mental health or less? Do all students manage equally at university, or are specific groups likely to struggle at university? Does the type of university that you attend have an impact on your mental health? So do students do better at small universities? Or actually does that large environment where you've got a big opportunity to connect with many different people have benefits? Is that helpful? I don't think we know the answers to these questions yet. And I think this is one of the reasons why I'm very excited. Sorry, not I think, I know this is one of the reasons why I'm very excited about the toolkit, because I really hope that the sector might get better at collecting cohort data across institutions and sharing that between institutions to help us pull together this picture of how patterns of mental health amongst students vary across institutions, across faculties of study, dependent on different demographic backgrounds. We need an awful lot of will to make this happen, but I think at least the first step is having a consistent set of measures that the sector might be using. We're going to pull into the conversation later this morning. I don't know if she's aware, but I'm going to put her on quite such a pedestal, but Jax, who's been doing some amazing work at Bristol. Yeah, don't look so panic, but Jax has been doing some fabulous work at the University of Bristol, collecting data across the university and starting to analyse that and giving us a really rich understanding of the patterns that are going on at the University of Bristol. If we can align that approach across the country so that more universities are doing that, if we can be very ambitious and pull in the ideas that Emma and Paul have been starting to develop across their universities around sharing that data between institutions, then we begin to build a really rich understanding of what is going on for university students and how the environment in which they're studying might be impacting their mental health. So that is the sort of context in which we set about commissioning this work to try and understand what measures the sector might benefit from using so that we can move towards an agreement, a bit of a consensus around how we might assess students' mental health across the sector. I'm now going to invite Emma just to say a little bit more about some of the groundwork that went into setting up this project.
Thank you, Nicola. So following from Nicola's insights, we were aware of some key examples of some brilliant pieces of work being done in the sector, but there was still a lot of work that needed to be done in terms of knowing what was the need. And so back in 2020, we launched an online workshop and sort of an online consensus group where we just invited researchers, students and practitioners interested in looking at longitudinal data capture for student mental health and well-being. And what was really apparent in those online events was that there very much was a recognition that it's important to be setting up these longitudinal studies to look at multiple time points for students over time. However, what was also apparent was that there were lots of challenges and there was no one way in which that could be set up. And so one of the outcomes of these workshops was that Smarten decided that this is a key area that needed to be funded. So we then did a mapping exercise where any individual or researcher who was doing some research in this space, they kindly shared any surveys or any types of projects or protocols or ethics applications with Smarten so that we could map what data was being collected. So by data, we mean which well-being and mental health measures are being used, at what time points, and in terms of the other data, like demographic data and how students are being characterized, we did a large mapping exercise to see where the consensus is in terms of the data overlapping. And what we found is there was over 27 different measures being used to capture different areas of well-being and mental health. And when we look at the demographic data, there was just even more inconsistencies. And so that's where Smarten decided to launch our funding call to try to bring a team of researchers together to try to coordinate some of this amazing work going on in this space. And that's where it hands over to Paul, who will be talking about what some of the work the White Rose team has been doing later.
Thank you, Emma. I am there going to hand over to Paul. Paul, it's just, I don't know if you're going to say at the start of your talk, I probably should have checked this in advance, but would you mind giving us an overview also of the wider team that's been involved in the project? That would be a lovely place to start. And then, yes, please, can you talk us through the work you've been doing? Thank you.
Yeah, definitely. Yeah. I'm just going to share my slides. Okay, yeah, so I'm going to give you a bit of an overview of the whole project. And as you can see from the right-hand side here, there's sort of 18 plus different institutions right across the higher education sector that have contributed to this work. So this really has been quite a huge collaboration across different universities. And yeah, into the next slide as well, we'll look at this in a bit more detail about some of the different expertise that's been involved. And then I'm going to introduce the resource and talk you through it a bit and show you how it can be used to improve outcome measurement in cohorts. So firstly, a bit of an overview of the project. So yeah, Smarten funded this work as it's been described. It was to coordinate the running of longitudinal student cohorts across the university sector. So before this work began, there were a number of different cohorts across the country, either being run or various stages of setup. For example, York, Leeds, Sheffield, Bradford, Bristol. And some of these had started to combine together and group together to have some comparability, and others were being run independently. So yeah, one of the main reasons was to have some sort of comparability or standardization across the sector. So there's a number of objectives, and I'm just going to give you a bit of an overview of what was happening in the project. So firstly, one of the objectives was to provide guidance for universities who are looking to establish longitudinal studies. So we ran a series of cohort clinics where people could come to receive advice and guidance on setting up cohorts, or we could troubleshoot if there's any problems that had come up. Secondly, to provide an open access cohort starter kit, which is essentially a pack of documents that contains standardized study documents that researchers can adapt to their own institutions. So this includes things like study protocols, ethics documents, participant-facing documents, and things like that. So it's partly these things are to help with the standardization and partly to make it easier for other researchers to set up their own cohorts. Thirdly, one of the objectives was to explore opportunities for data linkage and sharing across universities. So this includes things like making use of data that is routinely collected about students, for example, things like access to counselling services, and including that within these data sets. And it's also about sharing it across universities. So, we hope that there'll be some comparability across the data so we can do more large-scale analyses and see how differences compare across the sector. And we hope that there might also be some opportunities to pull data together to conduct large-scale analyses. And the fourth objective, which is the one that I'll be talking about mostly today, is to establish agreement across the sector about procedures for collecting data, including which standardised measures to use. So there was a few different groups of consensus groups that have been run. Today I'm going to be talking particularly about the ones that were run around outcome measurements. Okay, so a bit of a background and overview of this. As part of this outcome, we ran a series of workshops that were consensus group workshops to establish this guidance. And this included people from a really wide range of backgrounds. We've got the full author list of this publication on the right. And this included a real wide range of expertise, included academics, student representatives, clinical academics with experience. So this includes a professor of clinical psychology. It includes the head of student counselling service. There are managers from student services. And there are also people with expertise in psychometric properties of measures and analysis of these measures as well. I really can't tell you just how much discussions, how much thoughtfulness, and how much work has just gone into producing this resource. It's a lot of work. So what we did was we developed a toolkit to help researchers make decisions about what outcomes to measure and how to measure them. And we didn't want to be prescriptive in these recommendations. From my experience, trying to tell a bunch of academics what to do doesn't tend to go very well. And we thought there was going to be a lot of different contexts across different universities. Different universities might set up cohorts with slightly different aims or different priorities. We made a number of recommendations, but we wanted to develop this toolkit which would help researchers make decisions about their own cohort. As part of this, we agreed broad outcome areas that should be measured as part of cohorts. We then identified a number of candidate measures that would be appropriate for student cohorts. And the consensus group agreed on 10 criteria, which were deemed to be important for measuring outcomes in student cohorts. And then these candidate measures could be judged against these criteria, and we could make recommendations based on this. So we actually developed a number of sort of soft recommendations about a core set of measures and which measures to use. Also this can just be used by researchers to make their own decisions on what to include. And I'm now going to talk through these last points and how we developed this. So firstly, consensus group reached agreement that there is value in recommending a core set of areas that should be measured. We recommended 4 areas that should be measured as part of, that we thought should be measured as part of any longitudinal cohort study. This includes not only general psychological well-being, but also general psychological symptoms. And it also included anxiety symptoms and depressive symptoms, because these are problems that are commonly experienced by students. The consensus groups also thought that they reached agreement that there was also value in making recommendations about a wider set of areas. So these 7 different problems here which commonly affect students, things like eating concerns, functioning, loneliness, sleep difficulties, and substance use, which includes alcohol and drugs. We didn't think that, we thought that not all studies are going to want to measure all these domains, but we recommend these as potential outcomes, for example, in York, we're quite interested in loneliness, so we've included loneliness measures based on these recommendations. If researchers are interested in this, then they can use the decision matrix toolkit to sort of guide their decisions on what measures to use. So next, I'm going to talk about how potential candidate measures were identified. They were identified predominantly by using systematic reviews of measures. We used the COSMIN database to identify systematic reviews of different measures. And we managed to identify them for most measures, most outcomes, apart from in some cases we had to use other sources. So, for example, we couldn't find a systematic review of depression measures that was relevant. So in that case, then I think it was the Royal College of Psychiatrists had published some guidance about depression measures, and it's reported on some of their different components. So we were able to use this instead. We included some limitations on which measures to include. So we only included self-report measures, and we only used measures that were designed for broad adult populations. So for example, we didn't include the geriatric depression scale, which is intended for older adults. And if a measure was intended for a particular subgroup population, then this would be excluded. So for example, a measure that was looking at like postnatal depression, because this wouldn't really be relevant to the broader student population. And there was also some additional limitations for particular domains. For example, for anxiety symptoms, we only included measures of generalized anxiety disorder and not measures that of specific anxiety components or specific anxiety disorders or phobias. And for another example of a limitation was psychological well-being. So we only included measures for this domain if they focused exclusively on psychological well-being and not including questions of physical well-being. So once we'd identified these candidate measures, we could judge them against 10 criteria, which had been agreed upon in the consensus groups. So yeah, in the groups, there's a lot of discussion about what's important in selecting these measures. And these 10 criteria here were deemed to be the most important. So firstly, psychometric properties. So this was deemed to be very important. For these criteria, we just made a simple evaluation criteria. So each measure could be compared to these 10 criteria, and it would receive basically either tick or a cross for each one, depending on whether or not it met the criteria, or a question mark if there was some uncertainty. The first one, psychometric properties. So the measure would have to have some original research paper that was exploring sort of indicators of reliability or validity, or if not an original research paper, some sort of review or some sort of publication that was exploring this. Secondly, sensitivity to change. So obviously with these longitudinal studies, it's very important that we're measuring change and tracking change across time. So we wanted to include measures that specifically had some sort of original publication that was that had sort of shown that they could measure sensitivity to change. Thirdly, the consensus groups thought it was important that these measures are acceptable to student populations. So we didn't expect many measures to have been to meet this criteria. So for this one, it wasn't okay for the measure to have just been widely used in student populations. We were looking for some original research paper that was exploring acceptability in students specifically. And that could be either quantitative or qualitative studies. We didn't expect many measures to meet this criteria. Fourthly, we thought it was important that the measure had acceptability to other key stakeholders at universities. So again, we're looking for similar criteria, some sort of original publication about this. And these key stakeholders, that would be people who have some sort of responsibility for student mental health or well-being. For example, staff who work in counselling services. Number 5 was if the measure was specifically designed for student populations, in which case it would be tailored to that population, which would be quite advantageous. And again, we didn't expect many measures to meet this criteria. Number 6, whether the measure was designed for non-clinical populations. So a lot of measures of psychological symptoms were developed for clinical populations and not for general populations. So I think a good example is the PHQ. This was originally designed to be used in psychiatric settings or other healthcare settings. And it wasn't really intended to be used in general population settings, but this is how it's quite commonly used. So yeah, we wanted to really look at this criteria, and yeah, we thought it was quite important to identify measures that were intended for general populations and not just clinical populations. 7, we thought it was important to have comparability with NHS data sets. This is very important, so we can compare student outcomes compared to general populations. And with this one, this is particularly thinking about how outcomes are measured in NHS talking therapies for anxiety and depression, which was previously referred to as IAPT. Yeah. 8th, we thought it was important that the measures would have some sort of comparability with university counselling and wellbeing service data sets. So yeah, a lot of university counselling services routinely use measure outcomes. We wanted these longitudinal cohorts to have comparable data to these counselling services. Number 9, free to use. We thought this was really quite an important one. Some measures you have to pay a license fee. You might have to pay like a one-off license fee, or you might have to pay a license fee every time the measure is used. But we thought it was important that these measures would be free to use. You know, this is to reduce the costs and yeah, minimise the burden of running these cohorts. And number 10, we thought it was very important that the measures should be brief. So yeah, this was to improve the response rates to surveys in the cohorts and to improve the completion rates. We didn't want it to be too burdensome for participants. So yeah, we thought it was important to include brief measures. So yeah, for the first 9 points, then when they were rated, yeah, it was, as Sarah mentioned, it was sort of a yes, no, or uncertain. And for the number 10, we would report the number of items in each measure so that researchers could make their own decision about it. Yeah, and you know, if there was, we'd include like all the versions of the questionnaire. So some of them might have quite long, and then might have shorter versions. So we'd report each so that researchers could make that choice. So next, I'm going to just look through a few examples of comparing these candidate measures against these criteria for different outcomes. So the first one here is measures of general psychological symptoms. So on the leftmost column, we have the different measures, the brief symptom inventory, measures in the core family, and then the general health questionnaire. Then in each row, we have the different 10 criteria. So we can see how they all sort of compare and measure up to one another. So in this case, for general psychological symptoms, we think that, well, we think that the core came out as quite a front runner. So you know, they all have a tick for like psychometric properties, sensitivity change. There's quite a bit of uncertainty about their acceptability, but the core outperformed the others, and it's used regularly in NHS data sets and in university counselling data sets. So it improved the comparability, and also it's free to use, which the other two weren't. So yeah, this one stood out as a real, we did make quite a recommendation on using this one. But obviously, you know, researchers are free to use this criterion and decide for themselves what might be most appropriate for their study. And then within the report itself, there's a bit more discussion about the different versions. So for example, within the core family, one of them, the core 10, that has this 10 item measure, or there's the GP core, which is a 14 item measure, slightly longer, but the GP core is intended for general populations. So we think this is probably going to be more appropriate for student cohorts. So yeah, in this one, I think it's quite a clear sort of front runner here. But for the next example, it was a bit less clear. So this is for depression measures. So yeah, there's a few more measures here to choose from. Yeah, they've all got a tick for psychometric properties and sensitivity to change. And again, not much is known about their acceptability to students. One, the CCAPS, second one down, that was actually designed specifically for student populations. And it's used in measuring outcomes in student-based counselling services, which is quite advantageous there. However, the measure isn't free to use. Another one that stands out, the CESD, that one was specifically designed for non-clinical populations, and it's free to use, so that has its advantages. But I think we made a bit of a soft recommendation about using the PHQ-9. So this one is quite widely used, and although, as I mentioned, it wasn't designed for non-clinical populations, I think there might have been quite a recent study that did validate it in general populations, but I'm not certain on that. But yeah, it's quite widely used, so it has comparability with NHS datasets and university counselling datasets, and it's free to use as well. So here, we're just looking at a bit of an overall summary on the recommendations we've made. Yeah, it was recommended that 4 core areas should be measured, and we've made a bit of a soft recommendation on which measures were standing out as the most appropriate. Obviously, we'd encourage researchers to read through the guidance and sort of make these decisions for their own cohort. So yeah, the 4 measures would be a core battery of using the GP core for psychological distress, the WEMWEBs for psychological well-being, the PHQ for depression symptoms, and the GAD for anxiety symptoms. And then we've also made some soft recommendations at the bottom here about what measures might be the most appropriate to use for if researchers wish to measure other domains, for example, the UCLA for loneliness or the audit for alcohol use. But I think with some of these bottom ones, there was a lot less certainty, particularly ones around the eating concerns. We're a bit uncertain about the acceptability. So yeah, I'd encourage researchers to sort of read a bit about the discussion included in the report about this. Yeah, a few points worth discussing. Yeah, we thought there was very little evidence of acceptability of these measures in student populations. So we think that there might be value in further work to evaluate the acceptability of these measures in student populations. We thought that there may be value in using the same approach to identify and evaluate candidate measures for other constructs before their use in student cohorts. So obviously researchers may have other priorities that they wish to explore. For example, I'm quite interested in help seeking. So I looked at the candidate help seeking measures and basically followed the same sort of procedure to identify and measure there. Yeah, so researchers could use the toolkit for this as well. Yeah, and then here's a link to some of the resources we talked about today. Yeah, researchers can access the full report and the decision matrix tool that we've talked through. And some of the other points I mentioned at the start, if you follow this link, you can access the cohort starter kit and the full document pack. And yeah, we don't have any upcoming plans for any cohort clinics, but we're very open to being contacted. And if researchers are thinking about setting up cohorts, or if you're already setting one up or you just want to chat it through, then yeah, please do contact us. We'd be very keen to hear from you. Yeah, thank you.
Thank you, Paul. That was wonderful. Thank you very much. And if it's not clear in listening to Paul talk through this, it has been an unbelievably huge amount of work that Paul and his team have put into this. I think doing it alone anyway is a huge piece of work, but what I'm really impressed by is the amount of consultation that has gone into putting this together, and those workshops that you ran at the beginning in terms of trying to bring the sector together to think about what we should be doing and prioritising. So Paul, thank you so much. Just before we introduce, so before I bring in our other guest speakers, Emma, I wonder if I could come to you just for a very quick note. Paul was highlighting across that presentation the sort of a distinction between measures that were designed for use in the clinical population versus ones that are designed for use in a general population. And I wonder whether you could just answer a question on, is it really problematic to pick up measures that were designed for a clinical population and use them in a cohort study? What would be the risks or the challenges in doing that?
Thanks, Nicola, and thanks, Paul. I was frantically writing notes as you were speaking, because it's all very relevant to so much work in this space right now. So I suppose briefly, there's perhaps 3 or 4 key considerations that we can think about some of the potential issues of using measures designed for the clinical populations, either to be used with students or in the general population. And the first is an issue for the context or setting. So the wording of a lot of these items are very medicalized and also westernized. So they're not necessarily designed to tap into these broader constructs. So in terms of some of these measures have potentially derived from diagnostic tools, so the aim to diagnose an anxiety disorder. So for instance, GAD7, originally being used to potentially diagnose an anxiety, now being used in broader terms. So there's a contextual issue in terms of being in higher education, working with students, and also the wording. So students might not resonate in terms of what they're reading in the questions in these items, in these measures. They might not associate their experiences with these over-medicalized terms. Paul also mentioned that there's very little research looking at the acceptability among students, but also when we look at the risk of using a clinical measure with our students, is that, again, because they're not necessarily designed to work with students, we know that historically, while there might be research today showing that the mental health needs of students within the student population has been deteriorating over time, when we compare that to the general population or the general clinical population, students aren't necessarily as impaired. So again, these measures are designed to pick up on issues with a slightly more impaired population. So they might not be sensitive enough to tap into the unique needs of students, and they might not be broad enough. So there are issues for our services as well. So student services no longer only offer counselling, clinical psychotherapy services. There are broader needs for students. And so if we're only using clinical measures, then we're not tapping into these broader constructs of psychological well-being, functioning, problems, relationships, sense of belonging, all of these other issues. There are more issues when we get into the psychometric issues, but I won't get into that technical conversation. But there's more work like that going on in this space. So hopefully there'll be more papers coming out this year to tease out some of these issues when we're trying to use clinical measures within a non-clinical population.
Emma, thank you so much. I hope I've found that helpful, but I always find Emma very helpful on this, and she's my go-to for trying to understand what tools we should be using. I'm really fortunate this morning to be joined by Kieran Ballou, Margaret McClafferty and Jax Bennett, who have all been doing fantastic work looking at student mental health and using bigger data sets. I'm just going to ask them to give themselves a quick introduction. Sorry for not doing it for you, but I think you'll do it very nicely for yourselves. And then I've got a few questions to get them started, and then hopefully our audience can open up for general questions from everybody. Jax, can I come to you first?
Of course. Thank you very much. And great to see so many people this morning. I'm Dr. Jax Bennett. I'm from University of Bristol. I'm a senior research associate in the medical school. My interests are population health interventions in university student populations and characteristics and factors that are related to mental health and academic outcomes. I've analysed and reported on Bristol's mental health and wellbeing data for the last 5 years. And I'm lucky enough to be starting an ESRC postdoc fellowship in October. And I'm going to have a particular focus on the short Warwick and looking at cohorts, joining up the dots across the UK using a cohort measure that potentially goes out at registration.
Thank you, Jax, and congratulations, and looking forward to seeing so much more wonderful work from you. Margaret, can I come to you next?
Yes, no problem. Thank you for having me here today. So I'm Dr. Margaret McClafferty, and I'm a research fellow in Ulster University in Northern Ireland. And going back to 2015, I've been involved in the Northern Ireland part of the World Mental Health International College Student Initiative. which is a longitudinal study being led by collaborators in Harvard. And they've collected data from universities all across the globe, some really, really interesting findings. Through my involvement with Smarten, I was absolutely delighted to be involved in the consensus group for this cohort design. I just think it's so important. While we were able to look at data globally, unfortunately, as we were the only college in the British Isles, we couldn't compare anything really, I suppose, from standardized measures nationally. So just delighted to be involved in this, and just think it's such an important part of the research process going forward. Thank you.
Thank you, Margaret. And lastly, but definitely not least, Kieran, can we come to you?
Thanks, Nicola. So my name is Kieran Ballou, and I'm a senior lecturer at the University of Southern Queensland. And my sort of background in this area really originates in an ESRC funded project that Nicola is actually an investigator on. And what we were looking at is thinking about longer term outcomes beyond university into early adulthood, and thinking about the role of the university environment, but also taking into account the social characteristics of individuals and their backgrounds. So trying to understand how intersectionally, how different background characteristics, social, economic status, gender, that kind of thing, how these things come together to maybe predict outcomes. And we looked at a range of different life outcomes in terms of also thinking about employment and education outcomes, and the role of mental distress in adolescence and how that kind of predicts these longer term outcomes. And the main data set that we've been working with is the Next Step study, which is also known as the longitudinal study of young people in England. They actually have a new wave, I think, that should be coming out actually probably next year, when the individual's about age 31. But we were looking really at outcomes up to about age 25. And yeah, I see Nicola's just put one of our studies in the chat now. And essentially, yeah, we were the main mental health measure in that data set is the general health questionnaire that Paul was talking about just now. But one of the things I'll probably talk about a bit later on is how we had to look at, because we're fairly limited in terms of measures, because obviously the data sets weren't designed for this purpose, thinking about other proxies for different wellbeing measures.
Thank you. And I've put a few links to some of these people, some of the work in the chat for you, just to reiterate, these guys are really, really exciting work that's going on here. Can I ask all of you a question just to get us started? And I hope I'm not putting on too much of a platform to praise the work that Paul's done, but I think it does need an awful lot of praise. I wonder if you can think about how the sector might benefit from better cohort data, and better might mean sort of more cohort data. It might mean better alignment, which I hope Paul's toolkit should allow us to achieve. What do you think we would gain from better cohort data? Margaret, can I come to you first?
Yes, of course, no problem. I suppose I kind of alluded to that earlier, but I mean, as I said, I think it is just so important that, we are comparing like with like. When you're looking at student data, I think that's what we find most frustrating, in that, loads of different colleges are doing work on student mental health, but just when you try to compare them, it can be difficult. Now, within our study, the last one that we did, the last cohort that we recruited back in 2019, we had, it was a cross-border study. We got funding from Kyten to do a large study in the Republic of Ireland and in Northern Ireland. And for example, that was the first time that we had really looked at another college. And even though it was, quite, they weren't that far apart geographically, because we think it was because it was cross-border, there was huge differences found, really, really interesting data from that. And I think, you know, the more that we can compare, definitely the better. And I think that will really tease out and be of great benefit to a lot of people, both students, academics, policymakers.
That's really interesting, Margaret. And it's interesting that you're pulling that out, but it's possibly cross-border. But actually, at the moment, you're only comparing 2 institutions, so it could be many different. I'm not critiquing you, but going at the invitation for others. Let's have more of this data so that you'd be able to know, is it a cross-border thing, or is there something else going on in the difference between these 2 sites?
Yeah, no, definitely. I mean, like, I know I've spoken about this before. Like, I'm actually hoping to set up a network on the island of Ireland, and to try and expand this work right across, across the island as such. But to be able to, even like to be able to compare data in Northern Ireland with the UK mainland, I think, to be able to compare like for like, it would be just so beneficial, because there's so many differences.
Thank you.
As well.
Jax, do you have anything to add to that?
I do. From a zoomed out perspective, I think with the numbers of students who are actually seeking support while they're studying growing year on year, and obviously there are budgetary constraints for universities across the country. Unless we know what works and for whom, in a joined up way across the country, we're operating blind, really, and that's where these population studies, where we can actually look at interventions that work and track them across time, which not least students who are potentially more vulnerable. But actually, when a university spends money on an intervention, whatever it might be, whether that's a change to pedagogy or support services, being able to track across the whole population the impact is critical in my view, and the only way to do that is with cohort studies.
Thank you. And Kieran, is there anything else you'd like to add to that?
Well, just to say that, I mean, the advantage of cohort studies is they're rich, often large, and representative. And I think you often don't get that with a lot of the studies that are done within student samples. There may be sampled within a few different universities. I know Emma's done quite a lot of work actually with this, but I think that's probably a lot of the studies don't go to the scale that Emma does in terms of multiple universities. So the cohort data sets are really great in terms of getting that representation across a much larger area of the sector. The main issue is that they're, I mean, to my knowledge, at least my experience, is they're not really designed for this purpose. They're designed for longer term outcomes, but they obviously have to capture a range of different outcomes. So they're not necessarily designed to cover health and well-being, lifestyle, that kind of thing. So often what happens is when you then start to look at them, often you go, there's some very good rich data here, but just isn't quite what I'm looking for. And you always feel it's often a bit limited in that sense. So I think the work in this document is really going to help in terms of providing some guidance on that, because it's not very clear what those decisions are made, but the basis of those decisions, why did they decide to use these particular measures? Is it because they were brief, they were shorter, they were the most least contentious from an ethical perspective? There's all sorts of decisions that probably went into that, and it's not clear whether there's guidance is there to use these rich data sets to actually get a kind of representation, a representativeness across the country.
Thanks, Kieran. And I think you're talking primarily there about the LSYPE data.
Yeah, that's my main experience, and I think that that's a very rich data set in the sense that obviously, as I mentioned, they're continuing to collect data, and then we're going to have quite a lot of waves of information from starting from quite a young point. But then there's the limitations of things like, is there a measure at the point they're actually at university, or is it just before, just afterwards, things like that, and what limitation is caused by that. Obviously, a lot of these cohort data sets, they're not, they cover maybe a broad spectrum of individuals across different contexts, but not necessarily just students or and that, I mean, that obviously allows for comparison, and certainly in the work we've done, we're looking at students and those who didn't go to university, but then it comes back to the point of, well, then are there measures appropriate for specific issues that students might be facing? So yeah, I am particularly obviously focusing on the LSYPE data set when I talk about that, But I'd be curious to hear from others about whether they feel that there's similar issues with other cohort data sets.
Kieran, thank you. Just a little note for our wider audience. I'm going to ask one more question and then open up for the wider audience if you've got any questions. So do have a think if you've got questions that you'd like to ask. If you'd like to pop them in the chat in advance, feel free to do so. Otherwise, just pop your hands up and we will come to you. But before I open up, one of the things that I found most perplexing in looking through this toolkit is the lack of measures out there that are identified as acceptable to students. So it's really clear in looking at the work that Paul and his team have done that very few of these measures that we might be using that would be sensible to use, good to use for other reasons, very few of them, if any, I think, have been tested for their acceptability with students. And I wonder whether you've got any thoughts on how big a problem that is. Is it a problem we should be really concerned about? Is it just sort of something we should be a little bit uncomfortable about? Is there more work that needs to be done here? What do you think? Jax, you'd already unmuted yourself, so I'm going to come to you there. You should be desperate to answer this one.
So I touched very briefly on this in some work that I did, some PPI work that I did with students across my PhD. So we talked about measures, we talked about the wording of questions. And in broader terms, if you're asking a whole student population about their mental health and well-being, there are all sorts of issues about asking those questions in the first place and who's likely to respond to those kinds of surveys, the stigma that might be attached to responding to those surveys, or why you might want to input. So I'm sure that Emma is probably able to speak more specifically to the acceptability to students, but there has to be that sort of there has to be that sort of broader concession of are students actually going to take part in these surveys in the first place when you're asking about mental health and well-being, and what's the springboard and the starting point for that?
There's a nice challenge for us, Jax. Thank you. Emma, can I ask you to come in there? I know your university, they do run a large survey. You've got a cohort study up and running, and you've partnered with several other universities. Could you tell us a bit more about the thought process that have gone into the precise measures that you've selected there? I know when I've chatted to you previously, there's a lot of thought about how do we actually get students to take part.
Sure. So to answer the question, but also to follow on from what Jax is saying, I completely agree that acceptability, like how students feel about completing these measures, I think it's essential. And it reminds me of undergraduate stats, something that my lecturer told me: bad data in equals bad data out. So if we're not measuring the things that we think we're trying to measure, then there's almost no point in trying to collect that data, because if students aren't resonating with these questions, if it's putting them off future help seeking, if they don't feel comfortable filling out these measures, then I think we're off to a bad start. And even though these measures are designed for cohort studies and research, we know that when we look at these measures being used in support services, because that is often also a goal of linking data sets, we want to know, are our broader student population, when we're measuring their well-being and mental health needs, are they getting through to services, the ones that need to get through? And so I know, Paul, I don't know if you want to talk a bit about some of the visions that you've got at York to link data sets across sort of the research and the service side as well. But when we look at the measures being used in services, there are already so many barriers to practitioners using measures. And so if we then have barriers to students, if students don't like the measures and there are some barriers to practitioners using measures, then it just feeds into an ongoing negative rippling effect of more and more poor data. So I think student acceptability is crucial.
Thank you, Emma. And there was an invitation, Paul. Do you want to let us know a bit about the linking?
Yeah, I'll just quite briefly mention, so we're just sort of setting this process up. Yeah, we're interested in setting up data linkage with sort of different services within university to collect data that's sort of already routinely collected about students and use that in the outcome measurement. So, for example, like access to like the university's counselling service, or wellbeing services. We've been asking people who've joined the cohort for their consent to access this data. And I thought it was actually a really good response. So I think for like the access to the wellbeing data, just on a sort of very brief pilot test, I think about 80% of respondents had agreed to that, which I think, you know, we hadn't really, we were doing minimal work on this. So I think that shows some quite reasonable acceptability. And yeah, I'll just say as well, I've actually been, as part of a different project, I've been doing qualitative interviews with students, and that has come up quite a lot, is a bit of reluctance to engage with counselling because of outcome measurement. Yeah.
That's really interesting. Thank you. I'm enjoying this conversation enormously, but I am also aware people are starting to pop their hands up. So I'm going to hand over. Denise, would you like to ask a question?
Hi, thank you. Yes, I'm really following on from what Jack said. This thing about acceptability, this conversation about acceptability is really interesting. And also on the other side, just for us to be aware, sort of how we ask the question also shapes the space. I know we've had these conversations, Nicola, but in the university space, we also have set up a whole discourse which actually requires students to identify themselves in this way, like to get extensions, you know, even in the sort of or at the level of a diagnosis, and to be able to get disabled students allowance and so on. There's a whole kind of set of discourses that use these questions in a different way, where students are, you know, required to identify themselves in a certain way in order to get certain benefits in relation to their learning. And there was that conversation earlier in the chat about medicalisation in the way we ask. I think there's almost a polarisation between the stigma that was talked about and the reluctance, and also the way we're pushing students in a certain direction in order, you know, it's well intentioned because it's about trying to make sure they get the support they need and all the rest of it, but in fact it's also almost requiring them to stay that way. Like if you're wanting to maintain additional supports for disability, you need to maintain your disability, don't you? So I think there's just an awful lot of interesting double binds that potentially get set up there as well. So it's not a question really, but it's an engagement with what Jax was saying. And I suppose, again, just looking back, Paul, and you and your work, looking at what's been published, what's been done already, and so on, and how that potentially also leaves us with the more medicalized route, because those are the things that are more likely to have been used in the first place. And some of the work is more recent, that's focusing more on functioning and well-being and belonging and things like that. So perhaps just a comment on the difficulty, you know, it's a huge difficulty, absolutely accept this, that it's right to try to compare with what you've done already, but it does also force you down a path that was set before you started.
Thank you, Denise, for that. And I don't think there's a question there, but if I can just summarise that, there's a real word of caution there, that going down this route, yes, we have a toolkit here that is drawn from the existing measurement set that's out there. It is quite medical, and there is a risk that we continue to medicalise the distress that students experience. And I think the best we can do is just to own that and be honest about it, and think carefully about the implications of cohort studies and the measures that go into them, because we will find what we measure, and if we're not measuring it, we're not going to find it. But those measures also change the group that we're measuring as well. Margaret, did you want to come in on an answer with that as well?
Yeah, just wanted, I suppose it just goes without saying. I mean, I think when people are, you know, thinking about doing cohort studies with students, you know, really, really important that that there's a backup there, that if you're identifying mental health issues, you know, that you have systems in place, you know, to support those students. I mean, like we would have brought in, like worked very closely with student wellbeing. I know it's probably, you know, it's quite obvious, but sometimes people don't think about it. And just in terms of acceptability, I mean, within our studies, like we would have had advisory groups, you know, looking at the surveys before they would have went to ethics and stuff. And in general, yeah, you know, like students were, well, there might have been some reluctance. I think in general, people really saw the benefit from it. And I mean, like I know from feedback from students, like we've had some really positive experiences. Like I often talk about this in a study. We had one guy that actually said that only for our study, if he hadn't got that call, that follow-up call, he actually wouldn't be here. So as you know, as researchers, sometimes we're focused on the stats, but I think, you know, when somebody's saying to you, you saved my life, you know, I just needed help at that time. You know, I think to be mindful of just, we're not just researchers looking at the, you know, making sure there's support there and adequate support.
I think that it's so important, Margaret, isn't it, that this is woven into any study set up in a university, but the university is fully bought into it and has got a clear pathway for responding to points where students are raising high levels of distress. Donna, you've been waiting for ages. I'm very sorry to have kept you waiting. Can I invite you to come in and ask your question?
That's okay, no problem. Thanks very much to everybody. Really valuable project. Just a quick question, really, that you've set up quite nicely for me, but I'm wondering why CAPS isn't more widely used, because that's the Counselling Centre one from the States. It's used thousands and thousands. It's been set up for students. It's not clinical. So I'm just wondering, I've had this conversation with Emma by email, but why is that not used more widely? Disclaimer, I have a survey that's ongoing at the moment and I've used CAPS. It seems to be well, you know, not many people go into the survey and leave halfway, so it seems to be well tolerated. So I'm just wondering why, if that was specifically for that purpose, why is it not more used generally?
Emma, do you want to start us on an answer with that?
Sure. So I can talk a bit about the research that I've done using CCAPS. So most of my research tends to look at help-seeking students. So it's students that have already made it through to services. And to my understanding, CCAPS has been designed as an assessment tool for counselling services. So although Sheffield, we find it's perfectly acceptable, but people do often balk when we tell them there's 62 questions in the initial assessment. When you've got briefer tools that do other things. At Sheffield, we've always liked that CCAPS is student specific. It's been designed for students, but it's within that help-seeking population. So it may well be that perhaps because it is designed more so to be a tool for services and researchers rather than capturing the needs of the general student population. So for instance, it doesn't have a measure of well-being within there. The subscales within the measure, it tries to measure things like anxiety, depression, hostility, substance misuse. It does have some broader constructs like family distress and academic distress. We like it for the academic factor in it, but it doesn't measure well-being, it doesn't measure relationships, so it doesn't tap into these broader sort of psychological functioning areas. It's more so not diagnostic, but more of an assessment tool to help profile what are the needs of students that we want to address in an intervention. So that might be why it's not being put forward.
Thanks, Emma. Yeah, that makes sense, because I'm looking specifically at mental health problems. I'm not looking at well-being at all. So that makes sense. I think the people that devised that measure, I think they tested it for non-help seeking as well. I'm pretty sure I checked that before I used it, because mine is just general population. It's not help seeking. So I'm pretty sure that I read in one of their, when they were testing the measure, that it's okay to use it for non-help seeking. But of course, because it's not been used very much in the UK, it's hard to get studies that show anything further than that. But until mine, of course. Hopefully, fingers crossed. Thanks very much, Emma.
Jax, I also saw you smiling there at the number of items in the CCAPS, and I just wonder if you've got any reflections on what feels like a tolerable length for a study.
No, it's literally about to write into the chat, isn't it? 62 items. And we've had endless discussions at Bristol about the 14-item Warwick versus the 7-item Warwick. It's what capacity students have got in potentially, if we come back to the fact that Bristol's been running a student wellbeing survey for the last 6 years, since 2018, and we look at where they drop out during the survey, sort of halfway through, when they've maybe completed a PHQ-9, a GAD, a few sort of demographic questions, and the shorter, the briefer the measures, the better, basically. Yeah, I mean, I can't imagine getting consensus on a whole student population answering a 62-item.
There is a shorter version of it. Sorry to interrupt. There's a shorter version, yeah. But for me, I'm only looking at that and one other variable, so it's been well tolerated. But yeah, I accept if you're looking at lots of different things, that's going to be quite burdensome, isn't it? Really, you know, that number of items. So.
And coming back again to that sort of overview of what the shortest measures, the least burden to students annually or biannually, where you might be able to capture data that actually speaks to what you're looking for. Those are still conversations to be had, aren't they? Because you've got to weigh up your comparability, the length of surveys, what you're looking for, what each institution's looking for. I think, is it the Healthy Mind study in the US that's been running since 2013? And that uses the PHQ and the GAD. I'm not saying that any of these are right or wrong, but when I was looking for comparable data, because Bristol uses PHQ and GAD, that was the only place I could look. That was the only place where there were large cohort studies using similar measures. There was nothing in the UK that I could compare it to.
Thank you, everyone. Michael, can I come to you for another question?
Yes, sorry. Thanks very much. The toolkit looks really interesting. And it's just a question as to whether or not it might be transferable, usable in a related context. And the thought here is that 2 very big student mental health surveys conducted just before COVID found that more than 80% of students who were reporting mental health problems at university said their problems started while they were still at school. And if you're looking at a longitudinal study, you'd probably look at what's happening to young people before they get to university and again, potential knock-on effect. Do you think that the toolkit would work equally well in a school environment, perhaps with sixth formers or younger pupils, or is this something purely, as it were, for a university, and you'd have to develop something different for schools?
Such a wonderful question, Michael. Thank you. But Paul, do you feel happy saying something about that?
It's not something I thought about before, but I guess it could be adapted. You know, some of the points that are more particular to university students, like acceptability to students and the counselling staff, might not be as relevant. I think it could certainly be adapted, and I think I'd recommend probably maybe going for a similar approach and using some sort of consensus groups, or maybe some sort of co-production methods to develop it, so that it could be tailored to what schools need as well. So I can see that. I can imagine that they might have quite different particularities. Yeah.
Sorry, I'm aware we put you on the spot there, Paul, but I mean, it's sensible points. And Emma, do you have anything you'd like to add to that?
Sure. So I completely agree with Michael and what Paul has just said. And the first thing that comes to mind is that I think that would be critical is transitions to university and capturing those changes. We know that there are certain situations that are unique to higher education, that it may well be that there's something to do with the environment, the assessment criteria, being away from home. There are things specific to higher education that can have a negative impact on wellbeing, but I completely agree that we do have subgroups of students with pre-existing needs that could be tapped into, or at least measured, or be made aware of when they're at the school age. So I think it's really important for, when we're looking at longitudinal, that first data point. That's one of the things that I think is particularly unique about the York project, and Paul, the cohort study you've set up there. It's getting that first data point needs to be before students are at university. And I mean, ideally, we're researchers, so we would always want to collect information the earlier the better. But I think getting information about students' wellbeing or mental health when they're at university is already too late. So bringing back that baseline to be earlier, not only for the measures, but I think also bringing in the qualitative work here in terms of student transitions. How are their experiences? How are they feeling? How are they prepared? I'm working on a paper at the minute, and I've been looking at the literature to see what are some of the protective factors against poor mental health. And what keeps on coming up is actually, if we can better prepare our students to transition to university, then that is still to this day a substantial protective factor against poor mental health. So I think if we're able to look at some of this longitudinal data capture within schools, then I think that would be ideal.
I'm just going to inject a small note of gentle, maybe I was going to go pessimism, but I'll go for realism. But it's incredibly challenging to get that data point prior to school. And I think probably prior to university, while young people are still at school. And I think possibly the best thing that we might want to aim for is, where universities are routinely collecting this data, is to encourage them to think about whether they can reach out before students start university to people that have applied to the university and collect a data point at that point. I suspect the other way to go would be for us all a bit more of a sort of concerted effort to engage with the national data set study designs as they get set up, to think about that track through. So Martin has definitely fed into the Millennium Cohort study a little bit more than I think people might have done previously, in terms of thinking about measures around students, the students in the student space. But we may be looking more towards longitudinal data sets to try and address these. Kieran, I'd love to come to you if you've got other things to say here, but also I wonder from your own data whether you've got a view on the, Barbara's asking for a check on this reference of 80% of students reporting mental health problems before they start at university. And I can't remember whether you know from the LSYPE data.
Yeah, there's actually a report using the LSYPE that I'll find the reference for in a second, and I'll put it in the chat, where they did actually look at during adolescence, I think about age 13 or 14, and actually looked at a time point then, their mental distress, and then whether they went to university or not. And that kind of gives some kind of measure, I suppose, for whether students are going into university already with pre-existing issues. One of the points I was going to respond to, though, I suppose, was about this kind of pre-university point. And I was just going to say that I think this is where the national data sets are actually really advantageous, because, as I said, they're not necessarily set up. They don't know, obviously, at that point. If they start during adolescence or even during childhood, we don't know whether the individuals who are participating are going to go to university. But then it does allow for the advantage there to actually have some kind of comparison. And then you could, depending on how you analyse the data, actually look, well, okay, we'll look at the ones who did go to university, and we can always retroactively go, well, okay, what was the, how did the mental health measures during adolescence kind of predict later outcomes? And I think that's certainly one of the advantages with the LSYPE data set I've used. But that comes back to that larger question we've been raising about providing guidance for those national data sets, because they're not set up purely for that. They're not set up to be student data sets necessarily. Are they using the measures that will be most advantageous for us to know, about these issues?
Thank you, Kieran. Emma, was your point on this subject? Yeah, sorry,
I was just going to add to what Kieran was saying, to also say that, again, although this is looking at the sort of clinical data sets, but there is some brilliant work going on at Bristol University at the minute, linking CAMHS data. So we're limited because, taking on Kieran's last point, we know that they will only be using PHQ-9 and GAD-7 within an NHS sort of psychological therapy service, but a project that we finished recently at Sheffield was looking at partnerships between universities and NHS services to try to encourage earlier help seeking and earlier referrals for students. And some of the work that seems to be happening in those spaces is linking, if we're able to appropriately and ethically link data between university and NHS mental health services, particularly CAM, so the children's services. What Bristol is doing and what some other universities are doing is that they're then embedding sort of proactive outreach, that if they know that students are about to start university, when they've already been engaging in a child psychological service in the NHS, then they can sort of try to streamline some of that transition and take some of the distress out by using proactive outreach to get them engaged with our support services in the university earlier on. So although again, it's not our broader psychological well-being of our student population, it's more at the clinical end, but there are hints of this data linkage and longitudinal stretching that time span happening in this space.
Thank you. And I just want to say, for those that are not so familiar with Emma's work, she's done a lot of fantastic work looking at that space between universities and the NHS. And Emma, could I invite you before you run off just to pop some things in the chat, because some of the other reports that you've been involved in leading, so I think they're very valuable resources. Denise, I've been making you wait for ages and ages and ages. Just no, after I've been to Denise, no one else has got their hands up at the moment, so we'll look at wrapping up unless other people have questions to ask. So while Denise is chatting, do feel like popping your hands up if you do want to ask a question before we wrap up. Denise.
I just wanted to insert something, some of the work I've been doing. So I'm a practitioner. I've been leading university support services, etc., just to give context, but also really interested in researching and looking at how to evaluate interventions, which is I think Jax and others mentioned that's part of the point of getting this toolkit together. And one of the things I've been working on is how you turn the measure itself into an intervention and something that is seen as useful for the student to be completing. And this overlaps with what you were talking about, trying to get sort of a measure beforehand. There are others who've worked on this variety of ways to have students complete something which is part of helping them make the transition. And so these are potentially less clinical and slightly more kind of functioning and resilience based and things like that, or well-being based, but engaging the student in actively using something which helps them reflect on where they're at, and then trying things out and reflecting again and seeing for themselves how things have changed is part of the kind of approach I've been taking. And I just wanted to sort of add that in as another option to consider when you're talking about acceptability and trying to get people to complete something. The more that they see something in it for themselves, and it can become something that they're actually using and could use again themselves, the more likely it is that you'd be able to sort of engage them in that repetitive use of it. You might need a sort of a narrative around that, and obviously in a university you can be working with students, you know, they're constantly reflecting on their learning, so this is just another potentially prism on that. Just wanted to add that in and hear what people think about that. I don't know, Jax, you mentioned something along those lines, whether you've been looking at your data in that way.
I'm happy to come to Jax. Just before I do, I'm just going to take a huge risk here and ask whether there's anyone from the Nurture You project on this call. I know the Nurture You project is being led out of Exeter University by Ed Watkins and his team. And one strand of it is working on an app that is designed to do that sort of twofold, Denise, that you're looking at, is collecting data from students, but actually also helping them reflect on what the measures that they're reporting on mean for them, in terms then of either self-help or referral to other services, and trying to do that link up. I'm guessing with the lack of response I'm getting there's nobody on the call at the moment, but I guess it would be if anyone wants to have a look at the Nurture You study, to Google them, and more will be coming out, I'm sure, in time, taking that approach. Jax, can I hand it? Is there anything you want to add to that?
Just reflecting on, not students reflecting on the measure itself, but Bristol used so where they asked students to take part in a wellbeing survey, they made sure that they responded to the findings. So the findings were published every year, publicly available, with a narrative around it that said, you said, we did. These are the issues. Students were asked, having faced a battery of measurements, they were asked, what are we doing well? What could we do better? And that was pulled into a report where the university said, we have changed this because you have told us about it. And the other thing that I would reflect on is, I'm not sure if you're aware of Professor Bruce Hood's intervention at Bristol, which was called the Science of Happiness course, which I think started back in 2018. And what we did at the beginning was that students took a short WEMWebs at the start, and they were encouraged to take part in groups as they went through the intervention, and they went to the lectures, and then they took a short WEMWebs at the end. So there was a level of, I can take part in this measure, and I can see that there has been a change, or there hasn't been a change.
Fantastic, thank you. I've just a cheeky little plug here, but here we're looking at this cohort data set. There is a report coming out from TASO, commissioned by the Office for Students at the end. It should be coming out at the end of August, with guidance on measuring interventions that are not clinical, but designed around to improve students' mental health or well-being or reduce distress. That there is guidance there, thinking about what can we measure that is suitable for everybody, not in that clinical space, but perhaps more focused on intervention assessment rather than sort of the cohort tracking. I think I'm going to I need some of you to feed back to Jo. So Jo Ward, our wonderful network coordinator at Smarton, I'm hoping to try and get some brownie points from her and end early, which would make her very happy. But I want to say thank you everybody for joining us, for the wonderful questions that you've been asking, but mostly also Paul, that you and your team, thank you so much for putting this resource together. I know it's going to be incredibly useful across the space. I hope it's really valuable. And Jax, Margaret, Kieran and Emma, thank you so much for joining us this morning and sharing your thoughts and reflections on this resource, and I really look forward to hearing more about the work that comes out of your activities, and I trust I'm excited to see. Fabulous. Thank you everybody for your time this morning. Take care. Goodbye.